you very much, Dr. Satapathy, and good morning, everyone that is connected on a Saturday morning. So thank you very much for being here today. Let me share my screen. So as was previously introduced, I'm going to talk about MetALD. Most of the information, as you can imagine, is not specific for MetALD. So bear with me to try to make an exercise and try to see how of the knowledge that we have for MASLD or ALD may apply in this different population, in this new entity, particularly where we are talking about therapeutic options and then on liver transplantation. These are my disclosures, none of them related to the content of this presentation. So as we were discussing, the aims for the talk today is to briefly describe the burden of SLD. So what we are talking about, why is this important? How many patients in our clinics are being affected by this condition? To describe the new definition of a steatotic liver disease, and particularly this whole new entity that is called MetALD. To understand the leading mechanisms of liver injury in this dual etiology, and to provide evidence on the assessment and the main intervention that we should do in this liver population, including liver transplantation. So when we look the data from the WHO regarding the potential year of working life that are lost and which are the leading cause, you can see in the left side of the screen how the red line is on the top ones. So, and this varies across regions, but still in every single region, including the region of the Americas, cirrhosis is a very significant cause for potential year of working life. And then when you look specifically what are the risk factors associated with this, you can see that two are the main ones, alcohol and obesity. So this makes sense. This is what we look in our clinics. We know that MASLD and ALD are probably, at least in the Americas, the two most important ones. Viral hepatitis, especially in some regions of Asia, can be also very, very relevant. And why obesity? Is because we know already from many years from this paper from Mariana Lasso in 2008 that obesity correlates with MASLD. And you can see how obesity has been increasing since 1975 to 2016, and almost 3 times. So obesity rates in the United States, for example, were around 10% in 1975, and now are closing to 35%. So more than 3 times the rates of obesity, and you will expect that that will happen with MASLD. Because basically, the prevalence of MASLD is very similar or correlate with the prevalence of obesity. So if we have a 3-fold increase in obesity, we should expect a 3-fold increase in MASLD. And the prevalence of MASLD is high. In this review from last year, trying to put together data from around the world, we found that the prevalence of MASLD is around 32%. And this represent the second cause of liver transplantation, and it's the leading in females. Alcohol is number 1 in males, but in females, MASLD is the number 1. So we know that the burden of MASLD is significant. What happened with alcohol? So alcohol largely depends on alcohol consumption. It's not the only risk factor. It's not only the amount. There are other factors that we will see, but alcohol consumption varies across the globe, and you can see that in the world, the average is 6.4. The number 1 region is actually Europe with 12 liters of alcohol per capita. And in the region of the Americas, it's around 8, according to the data that was published in 2018, but the data actually is from 2016. And you can see how there is different, even in the Americas, on the amount of alcohol. We, being the US, in the top part with 9.8 liters of alcohol per capita per year. This is pure alcohol. It's not 9 liters of beer. It's 9 liters of pure alcohol. And as I mentioned, this has been reflected on the trends of liver transplantation. If you see how the trends of liver transplantation for ALD, you can see here in purple, especially in males, how has been increasing as the number one. But this is also true for females. And although MASLD, which is the green one, is higher in females, it's still both are increasing and very high. Same here with MASLD in males. How much alcohol we can drink safely? This is a question that is not that easy to answer, but there is adding evidence that there is no safe limit of alcohol. This was initial with this publication in Lancet in 2018 that showed that even with one drink, you start increasing your risk of poor outcomes. And this includes everything. This is not only the liver. This is cancer. This is cardiovascular disease. So the lower the better, and the only safe amount or zero risk is zero alcohol. There was a follow-up publication in 2022 also in Lancet because there was an idea that these may be different across like age. So what is true is that young people that in this population was defined as less than 60 may be protected with low drinking, and low drinking was one drink. But over that, there is no safe amount. Sorry, elderly people, more than 60. In the young population, there is no safe amount. The risks start with the first glass of alcohol. So this information is probably particularly true for the population less than 60. More than 50, it may be a net zero risk with low risk drinking. But again, it's very difficult to apply these to individuals. That's why Canada changed their recommendation last year. And it was thought based on the NIH, the NAAA recommendation that, you know, heavy drinking or high risk drinking was with more than 1 per day in females and more than 2 per day in males. So 7 per week in females and 14 per week in males. That was more than that was high risk drinking. But I mean, less than that is not necessarily low risk drinking. So if you are female and you are drinking 6 instead of 7, is that considered low risk or not? So actually looking the data, and again, this is not only for the liver, this is in general, actually the low risk where you are, the risks are similar or slightly higher than the general population is with less than 2 per week for both male and female. So basically went from 2 per day to 2 per week. And that's considered low. Zero risk is 0. More than 7 is high risk, both male and females. And in the middle, well, it's moderate risk. So when it's not high, it's not necessarily low. So that is considered moderate risk. So I think the thresholds for alcohol consumption are changing. We are having more data. And the bottom line is that probably the amount of alcohol that we consider low risk in the past are not low risk anymore. What is the natural history of the disease? So MASLD, you can have normal liver, then you will have isolated steatosis, then you are going to have necroinflammatory activity, and that is MASH with the steatohepatitis, and then you can progress to fibrosis, including cirrhosis, and at any point you can develop a complication such as hepatocellular carcinoma. The alcohol-related liver disease is very similar to you. So if you heavy drink, you will develop a steatosis 90 or 95% of the time, and these are studies that have shown that the healthy population in heavy drinking can develop a steatosis as fast as within 1 week. So most of the population that heavy drink will have steatosis, but of those, 20 to 40% are going to develop fibrosis, and from those 8 to 20% are going to develop cirrhosis and the complications, including hepatocellular carcinoma. At any point of the disease, with or without cirrhosis, you can develop the inflammatory form, which is called alcohol-associated hepatitis. And this is a completely different entity, and we are going to touch a little bit on that. But basically, the natural history of both diseases is similar in one way, and it can be, especially at the early stages, difficult to differentiate. And that's why the new nomenclature put everything under the same umbrella. Because from a clinical standpoint, I'm trying to make things easier for clinicians, what you will see as a clinician is a patient that is referred to you because they did an ultrasound and they found fatty liver, right? They found steatosis. So you don't know when you receive the patient if what is the reason for this. It can be MASLD, it can be alcohol, it can be any of the specific etiologies, and you need to do the workup. But as a syndrome or as an umbrella term, the steatotic liver disease is going to have these patients. So you will have the criteria for MASLD. If the patient is heavy drinking, you will have the criteria for alcohol. But what happened with those patients that are in the middle? So in this, what we consider the moderate risk of alcohol consumption, and then the has some metabolic dysfunction, but is not necessarily MASLD. And even thinking that alcohol produces some metabolic dysfunction itself, right? So alcohol itself produces hypertension. Alcohol itself will increase triglycerides. So what happened with that population in the middle? So there you have the diagnostic criteria that are based on the like the metabolic dysfunction criteria used by our endocrinology colleagues for diagnosis of metabolic syndrome. So that can help you to kind of in a positive way differentiate between patient that has MASLD versus other etiologies. And what are the proportion of these using this definition? So if you use this definition, 30, and there is two publications that are slightly overlapping and not exactly the same, although both of them are using enhanced, but probably the difference are based on the criteria that they use and the specific population. But in any case, like steatotic liver disease is around 38% of the population, which is high. We know MASLD is around 32.5%. This is consistent with previous studies. But then how much is MetALD and ALD? So ALD was 1.1% using this definition. This is probably slightly underestimated, because if you consider, like from a psychiatric point of view, how many patients has an alcohol use disorder, that is around, in the US, it's around 6%. So most of those patients are going to have ALD, so probably this 1% is underestimated. And then MetALD, honestly, from the top of my head, I was waiting that it was going to be higher than this, but around 2.6%. The other paper by Brian Lee and his group in USC, published recently in Hepatology last month, showed that although the same numbers, MetALD 2.2, ALD even lower, 0.7. So again, I think it helped us to identify, although I believe that probably the cutoffs for alcohol are too high, and that's why we are not able to capture the ALD population properly. Pathophysiology, we know that in MASLD, the main mechanistic process is the influx of free fatty acids that are going to the liver, mainly due to lipolysis and insulin resistance, and inflammation. Gut liver axis has a strong role, as well as genetic and in the adipose tissue, and at the same time directly inducing de novo lipogenesis in the liver, leading to lipotoxicity. Also, there is a role in the MASLD, and the alcohol itself will disrupt the gut barrier, leading to translocation of bacterial and bacterial products from the gut to the liver through the portal vein. So we know that there is some risk factors that are for either of them, and then you have some risk factors that are common. For example, the ethanol production, lipopolysaccharide microbiome coming from the gut that can be seen in both the inflammatory response and then this lead to an accelerated fibrosis and disease progression. There is gene involved, and that's why probably we also see different susceptibilities in different populations. Probably the most studied one is the PNPL3 gene, and this is associated with lipid metabolism. And we know that this increases the risk not only of MASLD, also increase the risk of ALD, and also increase the risk of hepatocellular carcinoma associated to both entities. So this is also relevant and may be applied in the clinical practice in the near future. And this, again, is a study showing the PNPL3. But for me, the most important thing here is the combination, is what we call now MetALD, that I used to call dual etiology, that, I mean, if you have PNPL3, the allele risk, and you are not an excessive drinker, no obesity, and you don't have the gene, well, your risk is this one, is one, it's the reference. But then as soon as you start adding stuff, you have obesity but nothing else, or you have obesity but you are the carrier, you see how the risks start increasing. And the higher risk is actually the combination of excessive drinking and obesity plus the gene. And you can see that this is one of the cases where 1 + 1 is not 2, is 4, or even close to 8 in this case. So it's the synergistic effect of both the heavy drinking or the ALD and the MASLD. And these apply for the development of cirrhosis, but also for the development of HCC and the 10-year mortality. So again, this is some evidence that MetALD is an entity that it may have a significant progression of the liver disease compared to MASLD alone. And this is a very interesting picture that actually, for me, is very relevant because it's not only what you are seeing right now. So the patient will ask you, so what's the likelihood that I'm going to develop, advanced liver disease or decompensating, 1 year, 5 year, 10 year? What is the prognosis of this disease? So if you have MASLD and no fibrosis, your risk of having a liver decompensation is around 1% in this box here. If you have F4 fibrosis, your risk of decompensated 5 years with MASLD is around 5 to 15%. Again, let's go now to ALD. If you have ALD with no fibrosis, your risk of decompensation is 2 to 15%. So basically, this is telling you that ALD progressed much faster than MASLD. You can compare a patient with F1 MASLD, an F4 MASLD with an F1 ALD in their risk of 5-year decompensation. Actually, the 5-year decompensation risk for a patient with ALD and F3, F4 is 15 to 50%. So MetALD is kind of in the middle. So a patient with MetALD is not the same as a patient with MASLD in terms of the risk of liver decompensation at 5 years. So this is something that we need to have in mind, is the speed of progression of the liver disease. So let's go a little bit with management. So how we consider the management in this population. So number one is the proper assessment of alcohol intake. We need to ask properly to this patient how much they are drinking and try to quantify this or either in international units or in grams of alcohol. I think using terms such as social drinker, occasional drinker are not useful, because what is considered social, what is considered occasional? A patient can argue that, drinking daily is considered social. So I think we need to do proper assessment of alcohol intake. Then we need to screen for fibrosis in every patient, try to predict the liver disease progression, not only with the etiology, maybe genes may be involved, prescribe Mediterranean diet or low carbohydrate diet in this population, and promote abstinence or minimization of alcohol use. This is an algorithm from a recent review article from last year. It's busy, but it's basically showing you when you have someone with a steatotic liver disease, how you should approach, either if this is MASLD alone, ALD alone, or is MetALD. And again, most of the things are going to be common. So I think one of the main learning points from the new nomenclature is that we should assess, since these are the two most important things from a liver disease standpoint in every patient with a steatotic liver disease, is do a proper assessment of the metabolic dysfunction, metabolic syndrome, and cardiovascular risk, and prescribing statins and making sure that we are dealing with the cardiovascular part, because it's an important a cause of mortality in this population, but also properly assessing alcohol consumption in this population, and not being happy when the patient says, no, I'm drink occasionally. Let's try to dig on the alcohol consumption, not only in the current alcohol consumption, also in the past or historic alcohol consumption. Maybe the patient was a heavy drinking before, and now is drinking less. So we need to make sure that we are assessing those things. And this, for me, was a very striking paper coming from Austria in 2022, showing that in an MASLD, or even they use the definition MASLD and MASLD at that time, population, they did biomarkers of alcohol use in hair, which is called ethylglucuronide, and allows you to assess the previous 3 months of alcohol use. And they found that between 25 and 29% of the population consume alcohol heavily. In this population, considered the prior MASLD. So even when they were not reporting the alcohol consumption and they were labeled as MASLD, actually these patients were heavy drinkers. So again, I don't know if we need to use biomarkers for everyone, but these surely stress the point that there is an underreport of alcohol consumption. And how we can assess in this new population MetALD? Well, we will need to see how all these biomarkers are panels that we know performing this new population. I don't believe that we can just apply what is known for MASLD or alcohol. Well, if it's consistent and performs the same in both, probably you can extrapolate and say, well, probably this will be the same in MetALD. But if our biomarkers perform differently in MASLD and ALD population, probably for MetALD, we will need to prove and have new data. And so that's basically some of the proposals for MetALD, and how probably we can apply some of the things that has been applied in the general liver population, such as the FIB4, and then have and a stepwise approach, including, for example, transient elastography. let's go a little bit on treatment. So how we treat this condition. And we know that alcohol consumption, especially when it's heavy alcohol consumption, is not just about the willpower. It's not that just the patient is drinking because the patient wants to drink. It's a disease. Actually, it is categorized in the DSM-5 as a psychiatric comorbidity. So we need to try to identify those patients that has what we call alcohol use disorder. So it's heavy alcohol consumption that is impacting on the individual capacity to make decisions. So some of the diagnostic criteria are loss of control, are withdrawal symptoms, and the patient keeps drinking despite the physical, social, and even sometimes family consequences. So many of these patients will have alcohol use disorder. So we need to assess and we need to treat. And there is some interesting recent research around treatment for alcohol use disorder, and two that catch my attention because for me are drugs that we commonly use and also are drugs that we commonly use in our population with MASLD. So if they are treating the alcohol use disorder, can be very interesting in the MetALD population. One of them is the mineralocorticoid receptor system, the spironolactone, and the other one is the GLP-1 analogs. So spironolactone, this is interesting. This is a more population study, but what they saw was that all those treated with spironolactone, when they were matched by propensity score with other subjects that were not treated with spironolactone, reduced the weekly alcohol use. So patients that were on spironolactone, after adjusting for liver disease and all the other things that you may think that influence why someone will drink more or less, the patients that were on spironolactone were drinking less per week. So this was an interesting finding. And then it was a study one side with an animal model that corroborated that those in higher dose of spironolactone were drinking less. And also a pharmacoepidemiology study from the group of J. Luther in the MGH, and they showed that same when the patients were exposed to spironolactone had less drinking, even considered those with ODC score high, so most likely with alcohol use disorder. What happened with semaglutide? Again, this was observational, but showed that semaglutide reduced binge drinking. First, this was observed in a population, and then this study showed in an animal model how the use of semaglutide reduced the episode of binge drinking in mice, especially when they contain alcohol. So they reduce the binge. This is binge for sugar and carbohydrates, or reduce the binge for alcohol. And we will need to see with more potent GLP-1 analogs, and now with the dual agent or the triple agents with GIP and glucagon, how this is going to work. But you see how reduce this episode of binge after starting the medications. And again, although none of these studies has been yet been designed to assess the alcohol consumption, some of the kind of secondary or tertiary endpoints have shown that these patients are drinking less. So I think it's interesting, a molecule at least. Again, I want to stress the point that the risk of developing not only hepatic steatosis, but liver disease and all-cause mortality in patients with SLD is higher in the population that had ALD compared to MASLD alone, MetALD compared to MASLD, and also ALD compared to MetALD. So we need to think on the burden of the disease and the speed of progression. Liver transplantation, when we are going to suggest liver transplantation in this population, well, to make it easy, it's going to be, in my mind, either two scenarios. Same as the general population with MASLD more than 15 or complication of cirrhosis. And there is where you are going to refer a patient with MetALD for liver transplantation, or can be someone categorized as MetALD, especially considering, they underreport, and then they have episodes of binge drinking and they develop an alcohol-associated hepatitis. And let's try to apply some of the literature of alcohol in the MetALD. But alcohol-associated hepatitis is this particular entity. Philippe Mathurin from France published this paper in England in 2011, was kind of the seminal study for liver transplantation in ALHEP. And they showed a small cohort, very selected patient, but they showed a very significant difference in mortality. Then the Accelerated AH Consortium in the US, same, showed very promising results with a 1-year survival of 94% and only 10% heavy alcohol relapse post-transplant. One of the questions was, well, what happened with the relapse in this patient in the long term? So the French group, again, Alex Louvet, showed that there is no difference in alcohol consumption, the quick trans study, between those patients with heavy alcohol consumption and 6 months of abstinence, like the old 6 months route pathway, and those patients with severe alcohol-associated hepatitis. Here on the right side of the screen, we put all the studies together showing that there is a significant survival benefit, and the relapse is basically the same across all the studies, with or without the 6 months of abstinence. So again, we learned that the 6 months of abstinence is not the most important. It's abstinence, the time of sobriety, is one of the predictor factors, but it's not the best one, it's not even a good one. And so you can see how the liver transplantation for alcohol-related liver disease, and particularly for ALHEP, is growing, particularly in the US after all these studies, and how it's going to continue growing. What happened with relapse? And this may apply to patients with MetALD post-transplant, because these patients, if they had a heavy alcohol consumption pattern, they may have an alcohol use disorder and they may relapse post-transplant. This is from Accelerated AH, and again, not all the relapse post-transplant has impact on the graft or on the outcomes. If you look, like abstinence is in red, then late non-heavy alcohol use is in green, and this does not affect outcomes. With early and non-heavy use is some, but the most important one is the early but also heavy alcohol consumption. So that's the kind of the pattern of drinking post-transplant that we should be looking. If you look like the outcomes, if you had a late non-heavy use, your outcomes or your survival is exactly the same as if you were abstinent. If you have early non-heavy use, you will have a reduction, but really the most significant reduction on survival is with the early heavy use. What happened if you had a relapse and then your team is able to see that you had it, and then you are put on pharmacotherapy for UD or behavioral therapy, and you achieve abstinence again, so re-abstinence. So you can see that if you never had harmful alcohol use post-transplant, here the survival was 92. If you had harmful alcohol use and you were able to achieve re-abstinence, it's exactly the same. So it's not about relapsing or not. It's probably relapsing that nobody noticed and you are not on treatment. So those are the patients that continue the alcohol use and those ones that are mostly affected at 5 years post-transplant. So again, going back to the question, who is an appropriate candidate for early liver transplantation in the case that this patient will have a severe Hep? You know, we need to follow the clinical criteria. This patient has a very high mortality in the short term, is too sick to unlikely go any formal type of rehabilitation, and will have a significant benefit. And the psychosocial criteria that has low risk of relapse. Again, this makes sense. The problem in the context of alcohol, in particular alcohol use disorder, is the stigma around it. So we need to try to have as good objective criteria as we can. And this is a recent study. This is a common question, like, is this patient going to recompensate after the episode of AA? Sometimes people want to wait to see the patient recompensate. So recompensation is frequent. It's only 10% or less. Actually, in this study was 8%. So don't wait that the most likely scenario is that your patient after an episode of Hep is going to recompensate and not going to need liver transplantation because only 8% is going to recompensate. The long-term outcomes are possible, abstinence, that is what we are looking, but require long-term follow-ups and multiple interventions. So here we look all the patients transplanted at Mayo for ALD between 2000 and 2012. We found a 5-year survival of 76%, was even better than all the HOEs, and only 8% had a high-dose relapse, even with a longer follow-up of 20 years. So I think abstinence is possible, but require multiple interventions. And now we have more data. We know more predictors of relapse. So if the patient has good social support and no other psychiatric comorbidities and no prior treatment for alcohol use disorder, we know that those patients are good candidates for transplant with low risk of relapse. In this sense, again, the group from USC, Brian Lee and his group, has trying to develop, a scoring system, like objective scoring system, understanding that AUD is a very difficult disease to have objective scoring system because the disease itself is a psychiatric disease, which we can't measure with numbers as which we would like, to have a biomarker. But again, we know that the more you drink, failed prior attempts, legal issues, and other drugs are things that are risk factors that put you at high risk of developing relapse post-liver transplantation. And that's the SALT score. They did a whole AI score where like 13 questions, and this was a collaboration that they did with the social group from Twitter. And basically they found that, these 13 questions are highly related to a positive predictive value, so of heavy alcohol use post-transplant. So again, I think we have better tools to try to be objective and identify the patients that are going to relapse post-transplant, but it's never perfect, and I think it's never going to be perfect because the relapse post-transplant is influenced by many things. It's not only the quantity of alcohol, is not only the psychiatric comorbidities or the family history. We know that the insight, for example, and this is applied in our program, that the patient has insight that alcohol is the cause of the liver disease and they commit to sobriety is very important. In the past, we used to just rely on the length of sobriety. When the 6-month rule was in place, we said, well, if 6 months is abstinent, it's going to be abstinent. But now we know that doesn't work that way. Actually, this is probably the less important of all these other ones. We know that now one of the most important is not even in the patient, it's the social support. Is if this patient has a caregiver, and if that caregiver is committed to support the patient post-transplant. So these are the things that we need to assess. And don't forget that every time that we have a patient with ALD, and this may apply to the patient with MetALD, especially if they are heavy drinkers or meet the criteria for AUD, we have a patient that has two different diseases. In one side is the liver disease, and the other side is psychiatric comorbidity with the alcohol use disorder. And we are pretty good on the two boxes on the bottom side of the figure on the medical treatment of ALD, diuretics, non-selective beta blockers, antibiotics, all those things. We are somehow good in the nutritional intervention with high protein, low sodium diet. But we are, as provider, we are not that good on prescribing pharmacotherapy for AUD. Now, baclofen is the drug that has been trialed in ALD. There is reports now with acamprosate and naltrexone that is safe. But again, how these medications are going to act in the MetALD population is also going to help with the binge eating part, and maybe it's beneficial for both the binge drinking and the binge eating. So how this pharmacotherapy is going to apply in the MetALD population, that's a big question. And then behavioral treatment. So we know all these behavioral type of therapies like CBT, the cognitive behavioral therapy. This has been applied also in patients with eating disorders or with anxiety that we deal with anxiety is eating. So this may be an interesting way to treat patients that have something that is related to behavior, is either binge drinking or heavy drinking or heavy or binge eating. So we need to think that this may be an avenue where we can really help patients with MetALD. So as take-home message, MASLD and ALD are the leading cause of chronic liver disease. They are frequently overlapped. The new definition of MetALD is basically the MASLD with these more than low alcohol intake. These are the cutoff, although probably these cutoff are underestimating the role of alcohol. Mediterranean diet, weight loss, and physical activity should be encouraged in all the patients, and also identifying alcohol consumption. So we know that, especially in this patient that were considered MASLD, how we may be underestimating the role of alcohol, and we may need to use alcohol biomarkers. Again, there is potential new therapeutic targets for the dual etiology. Some of the interesting ones that we discussed were spironolactone and GLP-1s. And then liver transplantation, well, we will need more data, but I think we can apply some of the things that we know from the MASLD side, some of the things that we know from the ALD side. Particularly for the ALD side, I would say that keep in mind that some of these patients with MetALD may have an alcohol use disorder, that the relapse may be an issue post-transplant. Thank you very much, and I will be happy to take questions.